Hello, everyone. I'd like to thank you for joining us today or this evening, depending on where you are. My name's Dr. Henry Pollard, and I'm the head of the Research Commission of FIX, and this is one of our research presentations. Today, you're going to meet Dr. Amy Baxter, MD, who is our presenter. Now, Amy is an associate clinical professor at the Augusta University and CEO of Pain Care Labs, founded in 2006 to eliminate unnecessary pain. She attended Yale and Emory medical schools and founded the Pediatric Emergency Research Program at Scottish Rite. She's received federal research funding for neuromodulatory mechanism, mechanical stimulation research on pain relief, and has published and lectured nationally and internationally on pain management, procedural sedation, and opioid alternatives. She has a few inventions up her sleeve as well, just because she's not busy enough already. They include VibraCool, vibrational cryotherapy, Buzzy, distraction cards, and Duotherm, and her Buzzy device has blocked pain for over 45 million needle procedures. Other contributions include a hepatic enzyme algorithm timing child abuse, creating and validating the BARF nausea scale for pediatric cancer patients, and I love that title, identifying the cause of needle phobia increases, a prospective nasal irrigation COVID mitigation study reducing morbidity and mortality, and 10 plus patients on the pain blocking frequency. She's also occasionally known as the adopted granddaughter of science fiction grandmaster Robert A. Heinlein, if I pronounce that correctly. Now, I also got to say one special, if that wasn't impressive enough, we've dragged Amy out of bed at 2 a.m. to create this talk, so we thank her very much for that. So the title of the talk today is Why Mechanical Stimulation is Not Your Grandfather's Gate Control, New Science on an Old Subject. So over to you, Amy, and thank you very much.
Wow. Well, that was a very impressive recounting of all the different places that I've gone in my life and things I've done. I appreciate you having me to my time and all sorts of other interesting times around the globe. So this is really an honor to be here for everyone. I am really excited to talk about this because this is what I like to call physics medicine. And there's a lot of new and really amazing things that really since 2012, but primarily since 2017, we've learned about what gate control is, how it works, and I want to share that today, along with a bunch of other different approaches to pain management. One of the things I noticed as you were saying it is that my background is that some of what I've done started with procedural sedation, and I was doing a lot of ketamine, fentanyl, propofol, and now I'm really talking more about opioid mitigating strategies. So I think that really is almost paradigmatic of the way that the world is working. And fortunately, we're coming up with new understandings of the physics and physiology of the body to be able to make that possible. So Nikola Tesla said that if you want to find the secrets of the universe, think in terms of energy, frequency, and vibration. And that is never more true than what we're going to talk about today with the physiology of gate control. I believe that you touched on just about everything in my disclosure. So I do have a conflict of interest and won't be talking about products. Instead, I will be talking about translating new science into your practices. We're going to have two different sections. The first is that motion is medicine, which I think we all know, but how to support that, we'll talk about the physiology of gate control, the current thoughts with the never gets boring ice versus heat debate, and a little bit about how the brain's architecture is helping us in mitigate pain. So when we talk about pain, we're going to talk about the construct that I think we really understand that it's not just the physiology of what's happening in the tissues, that actually most of pain is occurring in the brain, and that any successful pain program not only needs to approach fear and focus as well as the physiology, but even move away from the word pain towards comfort and trying to change how the brain is perceiving a negative stimulus. So we're going to have two different people we're going to put this in the context of. The first one, we'll call him Gil. So Gil fell in love with a fellow runner, and they did the dopey challenge, and they got married. And then Gil was ready to slow down, but his new wife wasn't. So he comes to you because he's got bad IT band problems, and his wife wants to do a triathlon, nay, an Ironman. So he needs some help with that. And this is a picture taken about 30 seconds before a trip, a twist, and an ACL rupture. So the interesting thing about, we'll call her Jill, is that she's got a strong family history of opioid and substance use disorder. So how do you help prepare her for the pain of a surgery when she and her family want to avoid taking any outpatient opioids at all? All right, so let's start with Gil. And just to give a little bit of foundation, remind everybody of how pain transmission works. So there are peripheral nerve fibers, particularly the A delta fiber, which transmit sharp pain. They are on a very fast myelinated fiber that goes straight to the dorsal column, and then it's mitigated. In fact, about 90% of the nerves that are in the substantia gelatinosa are not going up or down. They're just modulating what comes in, crosses over, goes up to the brain. And the other fiber that sensation comes through is the C fibers. Now, if I'm trying to put sutures in somebody, I'm going to use sodium channel blocking to stop that myelinated transmission of the A delta signal. But for C fibers, there is no myelin. So this is going to be something that you're still going to be able to feel cold or deep pressure, even if you've got sodium channels blocked. But over time, that stimulus is going to increase. So let's talk a little bit about cold. So one thing that's been appreciated since really the late 90s, early 2000s is that cold can actually mitigate pain in places where you're not putting the cold. This is called conditioned pain reduction or descending noxious inhibitory control. But the concept is that the cold is brought into the dorsal column by the C fibers, and then goes immediately up, is processed by the thalamus, and then goes to the anterior cingulate cortex. The anterior cingulate cortex we're going to talk a lot about. The ACC is the arbiter of cognitive conflict. For example, if you have blue, green, red, pink, but they're written in the colors orange and blue and yellow and red, you have cognitive conflict. So it slows you down and it makes it difficult to read out what those words say because your brain is overwhelmed by the colors. So the ACC is mitigating this conflict, and it's part of what has to deal with the cold temperature. It senses that something is unpleasant and then decides whether or not it's dangerous. Once it realizes that the cold temperature is unpleasant but not dangerous, it actually decreases the perception of pain everywhere. Great example, if you're digging around for a drink in a cooler and it's not quite so cold, you have to take your hand out, but it's unpleasant, at that time you can tolerate more pain on your contralateral hand. So cold is not just locally working, but it's also an adjunct. Now, interestingly, it is on a different pathway. So you can get synergy by applying cold and another pain reducer simultaneously. One of the reasons that the Nobel Prize was awarded in 2021 was the discovery that pressure and temperature modify pain transmission. So both through the reaction of capsaicin and interaction with Messner corpuscles, but also that pressure and cold and how they relate to pain transmission. So this is some of what is causing this conditioned pain response. Now, that was one simple little pathway of thalamus, anterior cingulate cortex, back to thalamus, down to pain relief. This, I think, is one of the most majestic things that has come out of the Help End Addiction Long-Term initiative that the United States National Institutes of Health has put together. And full disclosure, part of what funds my research. The idea that the pain perception is not just one place in the brain, but actually a very complex interplay called a connectome. And as a corollary of that is that chronic pain, shown in red, has almost completely different brain connections when looked at under functional MRI than does someone who does not have chronic pain. And so this construct that the brain is perceiving pain in very different ways, depending on whether it's chronic or acute, underscores that pain is actually not happening in the periphery, it's happening centrally. Some people are saying now that pain is the brain's opinion of how safe you are, and even that pain is an emotion. So when we look at the fact that our brains are processing pain differently, it means that we need to look at different ways of teaching someone to approach what they're feeling so that we can deal with pain. All right, so let's go back to Gil. Now, Gil's like, I've done icing before, this IT band. It helps a lot if I do it after the pain is over. So there's a really great review I highly recommend by Dr. Brian Kunkel, and it's in the footnotes here, looking at all of the cryotherapy studies that have been done up until 2021. There's over 90 references in this. And the baseline that we understand is that cryotherapy decreases inflammation. It decreases pain by decreasing nerve conductivity and nerve velocity. And then vasoconstricts, which decreases edema, decreases swelling, and increases oxygen delivery to tissues. The decreased inflammation doesn't just decrease the cytokines that are inflammatory, but it actually increases anti-inflammatory cytokines. So together, they're combined for tissue healing. Now, I've heard so many different people say, ice is good, ice is bad. Really, this review, to me, granted, it's all in orthopedic surgery, but I think we will all agree that there's tissue damage when you have surgery. So I think it is very relevant to injuries as well. But to me, this really stopped any question of, is there any risk that is sufficient, even in microvasculature, to give us a logic for not using it? So the take-homes from this 90 some odd study review are, first of all, that applying ice with compression so that you get confluence of exposure matter. So using a bag of frozen peas, which has a lot of circles that are only touching the skin at one point, is going to be less effective than a flat surface that is pressed to the skin. So that was one take home. Over all of these studies, 44% of them found better pain relief than not using cryotherapy, and 46% found lower medications than not using cryo. So the point that I think needs to be driven home is that there were no worse outcomes. So analgesics were lower, activity was either equal or better. And interestingly, there are very few case reports. There are no large studies of decreased tissue outcomes. And of the case reports, all but one are in males. So one of the theories is that for females applying cryotherapy, because of the subcutaneous fat and an increased layer of insulation, you may have less risk of any damage. But the important thing to know is, even in the case that was published by Malone et al. Of 6 superficial peroneal nerves and other nerves that were injured, they all spontaneously resolved, and the athletes all did fine. And arguably, it was the compression in a band that decreased circulation rather than the 30 minutes of cryo itself that was a problem. So just to summarize, one of the things that I felt was interesting, we have a lot of debate here, not over whether to use cryotherapy or not, but whether to use the more expensive compression gadgets. And so looking at different outcomes of pain, medication used, range of motion, and swelling, most of those indications, there was really no difference between ice or continuous compression in an expensive device. It did, when there was a difference, it tended to be more in the continuous compression, with the exception of a pain and range of motion where the ice was better. There was some idiosyncratic application, but again, if it's confluently applied, then it doesn't seem to really matter what form it's applied in. Now, for Gil, he's got a chronic pain. And I think one thing that we're really learning more about chronic pain is that there is such an expectation part of a chronic IT band, a chronic tennis elbow. And so this was a really interesting study because for chronic low back pain, it found that either ice or heat that they randomized people to were both almost equally effective, and both were more effective than an NSAID. So this underscores that the volition and the agency of the person who's having pain, whether they use ice or heat outside the acute environment for pain, probably doesn't matter. So going back to how our pain transmission works, this is where we get to the fun goodies about the gate control. So you've got your A delta taking the fast, sharp pain to the spine. You've got a C fiber slowly taking pressure or cold. And now we get to the large fibers, the A beta fibers. So these touch receptors are the ones that inhibit the A delta pain. Melzek and Wall famously in 1965 discussed gate control, and the concept is you bang your hand with a hammer and you shake it, or you bump your elbow and you rub it. You're stimulating these mechanoreceptors. There are 4 different mechanoreceptors that we've got: the light touch Messner, there's the position sense Pacinian, there's stretching with Ruffini, and the stretching also are tied in with 1A and 2A afferents, and then Merkel discs for deep and prolonged touching. So 2012, a milestone was hit where they looked at what frequencies stimulated each of these and found that there are very different thresholds in fairly narrow bands for each of these. The thing that really, I think, changes what our clinical approach is that if you really want to block pain, you want to use the position sense Pacinian nerves. I mean, we kind of should have known this, because if you bang your hand with a hammer, you don't do light touch, you're shaking your hand. The implications of this, though, for what modality we use matter. Pacinians at 180 to 250 hertz are very fast. Now, we use a lot of electrical stimulation in the States, and most of the time that stimulation frequency is in the 40 to 60 hertz range, which is getting the Messner light touch corpuscles. If you're going to use mechanical stimulation, and the field is all over the board now. Casal in 2015 published a paper saying we really need to figure out what we're going to call this stuff, guys, whether it's mechanical stimulation or focal mechanical vibration or FMV, or high frequency, low amplitude vibration, HLFA. The field has not yet settled. And so when you're trying to find articles on it, there's a lot of different search terms. But the take home is that different frequencies have different effects on the tissues. And if you want to block pain, not only do you need 200 hertz, but you also need that vibration stimulus to be perpendicular to the skin. So you need the torque to be going into the skin rather than parallel. So a coin motor on your cell phone isn't going to do it because it's parallel. You need something penetrating to get down to the Pacinians. One interesting thing that's also been found is that vibratory waves transmit, and as they transmit, they stretch tissues. So you're picking up a little bit of Ruffini in addition to picking up the Pacinian. So comparing it, for those of you who are in an environment where E-stim is used, you can actually understand why electrical stimulation may not be as effective when you look at where the transmission goes. So if it's not implanted in the spine, but it's external, that means the electricity is arcing horizontally between 2 probes rather than going perpendicularly down to where the Pacinians are. Even in the professional units, they're rarely tuned above 150. But more importantly for the Ruffini's corpuscles is when you apply an amplitude of electrical stimulation, it's going to contract a muscle rather than stretching it. So these are a number of reasons that I think explain 3 decades of why gate control has not been as effective as we assumed it would be early on. There are a couple other benefits, and all of these are in different frequencies. These I'm about to tell you about are all in 150 hertz or higher, But delayed onset muscle soreness, there's ranges across the board. Slower, about 60 to 90 hertz, have been found for 5 minutes prior to working out to be as effective as 30 minutes of stretching or 15 minutes of massage for decreasing delayed onset muscle soreness. And I've got a bibliography of all of this if anyone wants it. For strength, vibration reversed hypertrophy of quadriceps. Now, this was done, and a number of these are done with a giant diaphragm. And so the diaphragm is triggered with sound waves or air to perpendicularly apply the vibration frequency. So a lot of the work that's done here is done in Italy, and they use a kind of percussive thing like that. Others use the eccentric flywheel, so you've got the torque going around in a motor. But range of motion increased, vasodilation increased, knee extension increased. And so what's happening is that on an ultrasound level, that the fibers are actually being stretched and separated atraumatically. So if you've got an overuse injury where there is lactic acid holding the edges of that muscle together as it goes to the tendon and the ligament to try to freeze it so it doesn't get further injured, the thought is that what's happening is that the vibration, the mechanical stimulation, are atraumatically separating those fibers, so you're not getting the re-injury. So for Gil, we're going to think in terms of energy, frequency, and vibration and suggest not a whole body vibration. This is more of a strength builder for older people. There's lots of benefits, balance. What is probably going on here is increasing the strength and the feeling of stability and decreasing the fear of movement. And so some of that is movement is medicine causing improved pain because of that, but it's not a local effect. So that's not going to help Gil so much. But for him, using a combination of ice and mechanical stimulation, in addition to stretching and working out, is what we're going to do to help repair for about 20 minutes twice a day for 3 days, help repair some of the tissues in the IT bands so that he can do his triathlon with his new bride, as he does often. So now let's take the case of Jill and an ACL reconstruction. And you want to avoid opioids. So this is really where we get into the connectomes and talk about how pain manifests in the brain. So first of all, does she need to be worried if she has a family history? So one of the things that we understand now is that there are about depends on, I put this in because there's so many different studies looking at ultra rapid metabolizers, but there is a metabolized chain in the liver that when it encounters opioids, it rapidly metabolizes it to morphine, to the mu receptor agonist. And this causes a rush. It causes an exhilaration, but it also goes away really quickly. And the estimations of what percentage of the population in different parts of the world and in different ethnic racial makeups vary wildly depending on which study you look at. When I did procedural sedation, we would have kids who would come in to get lumbar punctures for their ALL treatment. And there are a lot of teenagers who would actually enjoy coming in for these spinal taps because they really liked their fentanyl. And at the time, they're so young and they're certainly not taking any kind of medications outside of what we're giving them for making it more tolerable to have a spinal tap. So we would, like, oh yeah, I know you like your fentanyl, and give them a little extra time to have the fentanyl kick in before we gave them the propofol. I now realize that those were the kids who went apneic, and those are the kids that woke up and then we had to redose them. So it was probably about 1 in 5 of those teenagers that did it. And the teenagers were more often than the ones who were more likely to do it than not. But I realize now that they were almost definitely rapid metabolizers. They were going through their fentanyl quickly. it would hit them so hard they would not breathe anymore, which is fine. That's what we're there for. But then it would wear off and they would need a redose. So is Jill at risk if she has a family history of opioid and substance abuse? Yeah, probably. That's a reasonable question. So the other thing that's important to know when you're addressing a kid like this is, first of all, how do they deal with pain? Now this from something called hyperbole and a half, which is arguing that the pain scales we're using for rapidly assessing pain are really inadequate, and they ought to go further to how you actually feel in an emergency room. As a pediatrician, I can tell you that all of these reactions are things that we see when we just bring the vaccine out. And so knowing where someone's ability to tolerate pain and their fear of the pain is before you start making suggestions for them is really important, because if they are really anxious about the pain, then addressing fear first is very important. In the work that we did with injections and blocking pain, it quickly became apparent that the physiologic blocking of the sensation of the needle wasn't irrelevant, but it was a minor part of the pain experience for someone who had fear of the needle that was there previously. So with that construct in mind, understanding how to activate the anterior cingulate cortex to give someone a focus that will be so engrossing that they don't have fear of the pain is an important part of pain practice and pain management. When you look at the connectomes and the way that pain passes through the brain, there's a number of different places that when they light up, these patients have something called catastrophizing. So one of the three highest risks of opioid use after surgery, the first is opioid use before surgery. The second is how long you take the opioids. But the third is catastrophizing, which is a scale that looks at how overwhelmed are you likely to be about your pain and fear. And those who have a lot of fear, thinking I'm never going to walk again, I can't play my game again, I'm never going to hit the big leagues, my whole family is riding on me with this scholarship. Those kinds of perseverating and intrusive thoughts actually magnify pain. So understanding that before surgery to decrease pain is important. Post-traumatic stress, I think, is a really fascinating window into what the markers are that are related to pain. One thing we're finding with the HEAL studies are that there is actually a chronic pain switch, and this receptor, when blocked, will stop the production of chronic pain in rats. But the thing is, it's a time-sensitive reaction. So if you don't block the receptor early enough after a painful event, then that rat will go on to develop hyperalgesia and increased pain reception. I think this is akin to when a study out of the Lancet in 2010 that found that soldiers on the battlefield who were given morphine, the morphine amount in that first 24 hours was inversely proportional to their PTSD. So some of what we're seeing with post-traumatic stress can be increased catastrophizing and fear and pain perception, but some of it is probably also that prospectively, we need to make sure that early pain is addressed so that they don't perseverate and develop a PTSD to the pain from not blocking that receptor early on. Another great and interesting thing to me that we're finding out is that the brain actually changes size in response to chronic pain. So when we talk about chronic pain and hyperalgesia, one of the analogies that I use is that if you are a trained professional flute player and you go to the symphony, you are going to hear everything that happens in the flute section. Any missed note, any problem, you're going to hear it because you're specially trained in it. Just the same with chronic pain. You are expert in sensations related to pain, so you're going to feel more pain even if the tissues aren't having a problem. Different analogy that can be helpful for patients is to say that if you are in a house and you hear a strange noise, all of a sudden your hearing becomes hyperacute because your brain can focus intently on something that it sees as a threat. And if you've had an injury, your brain knows there's a threat, and it will be hyper attuned to feel pain from that area, even once the tissues are no longer causing signals that are dangerous to it. So that's where PTSD and the brain size come in. And 6 months after a total knee arthroplasty, the thalamus that had been enlarged in patients with very painful arthritic knees, thalamus shrinks down to normal. So this is just to say that addressing the way that Jill's brain is going to process pain, what her experiences have been up until this time, and what's going on as she's waiting for the surgery to reconstruct the ACL, those are all important things that need to be addressed to optimize pain relief afterwards. Obviously, if you're fearful and your amygdala is triggered, you're going to perceive more pain. I mean, this is the kid who comes in to get a shot and is already screaming before we even have the needle close to them, and they perceive pain with an alcohol swab. So all of these things together underscore that fear is important. And focus is the tool we're going to use to address these. So in that same area where catastrophizing happens and all of the things that can go wrong are also all of the options that can make pain better. So having easy, simple, controllable ways to address pain decrease the brain's perception of pain. There's something called acceptance and commitment therapy, and this has got wonderful data over the past decade demonstrating that with patients with chronic pain, if you accept that there's pain, commit to doing the activities you want to do, then as a therapy, it exceeds traditional chronic pain management like gabapentin or other pain medicines or rating pain. So one of the other things we're learning is rather than looking at a scale to determine how much pain someone has, what we probably ought to be doing is asking them how many activities that they wanted to do they've done, and what are they focusing on, and what do they want to achieve. Finally, the placebo effect has really been maligned in so many studies where we're trying to control for it and get rid of it. Have you ever wondered why we don't do placebo-controlled trials and parachutes? It wouldn't be ethical, right? Because we know that something works and taking it away wouldn't be ethical. And we also know that insulin would be a very bad placebo-controlled trial because you're not going to get a placebo effect when for giving a hormone that you're lacking if you have diabetes. So in the same way, those situations are ones where placebo doesn't work, and those are worth controlling to make sure there's no that there's a decent control. But for pain management, placebos do work. They work about 30%. And I think that what this is actually telling us is that we can get up to 30% pain relief from a whole bunch of different cognitive aspects surrounding pain management. So leaning into those and using them are important when you have someone who doesn't want to be taking pharmaceuticals. I like to say that fear and control are the volume knobs for pain. And teaching this to patients lets them know that by doing things to reduce fear and to increase their control, they will feel less pain. So this is good for them to know. So for Jill walking into her surgery, we want to make sure that she's got options and she knows what she wants to do beforehand. Ideally, she would pick some physical interventions that would be applicable to all of the different mechanoreceptors. Even though Pacinian is most effective and Ruffini is also a good adjunct, by self-applying and choosing different aspects like pressure or rollers or blankets, those are important. For the physiology, having heat options and cold options, even if it's heat on her shoulders distal to where the ACL reconstruction pain is, that's something that can be helpful. One thing to know is that mechanical stimulation, because it's a nerve-mediated issue, does not have to be at the site of the surgery. It can be proximal. And in order to decrease fear, having these tried out beforehand, before the surgery, so they're self-applied, she knows how to use them, those are important. And the fact that she can choose between them gives her anterior cingulate cortex something to do to reduce pain. A woman who I worked with in my pediatric life, who was a child therapist or a play specialist in Australia, she was wheelchair bound, and she had had over 100 surgeries when I met her. She said, here's how you need to understand pain. There are very few things that will just stop it or fix it. And some of those things, like surgery, are still going to take time, where the pain is worse before it gets better. So if you need to deal with pain, you've got to deal with pain, the over-the-counter issues, with supplements, with physical interventions. And she said, but when you start getting to physical interventions, just having a lot that you can try, there's always a combination you haven't tried before. Heat with a blanket, cold with pressure, stretching with softness. There's so many different ways. And when it comes to distraction and finding activities that you like to do, making a plan, calling people, having a book you want, having something that is distracting, all of those things, there's almost an infinite number of possibilities. So if you look at pain like this inverted pyramid and make your patients aware that they've got an entire spectrum they can build their plan on, they get something called the IKEA bias. Oh, I call it that. But if you put something together, if you build it, you like it better, and it's more likely to work. So for Jill, she liked the idea of rollers. So she got a roller for her hip, even though it's not where the pain of the ACL is, but it was something she could do, pushing on those Merkel discs and trigger points where she felt like it was helping her. She made a plan beforehand and had a whole list of people to call afterwards. And then she was using things like ice and heat and mechanical stimulation and pressure so that she could apply them when the pain got too much or while she was waiting for the next ibuprofen to kick in. Having options lights up the area of the brain that can counteract catastrophizing. So for her, she feels cool, and she's at college now. I'm sure she's doing substances other than opioids, but all is well. So last little tidbit that didn't really fit in anywhere, but it's something that everyone needs to know. Magnesium has 4 different ways that it can decrease pain. And it also can decrease opioids by 1/3 because it is an NMDA blocker. So neuroanti-inflammatory, reducing cramping, smooth muscle relaxer, and actually studies find that 500 milligrams a day decreases depression, which contributes to pain perception. So if you have patients who've got chronic pain and they're not taking magnesium, about 64% of people are magnesium deficient on any given day. So it's a really great adjunct. It's subtle. I broke my neck, and I find that when I start to have pain, I realize I haven't taken magnesium for about a week, and it takes about 2 days for it to start being effective. Your mileage may vary, but it's definitely something to have in our arsenal to offer our patients who are having pain-mediated issues that are stopping them from performing and enjoying their lives. Thank you very much, and I'll be happy to take any questions or debate you on ice.
Thank you very much for that very interesting and extensive talk. Just to kick it off, where do you see your research going from this point forward?
You know, it's a fascinating question. I'm limited in the United States by what our insurance and Medicaid will pay for. And they don't pay for comfort items, including mechanical stimulation. So the current project I have is an interplay of 3 different frequencies and a plate that has the ability to put hot or cold in it, and I can get harmonic interaction of that. But because of the payment, the first step on that journey to get that to patients is I'm actually I have an NIH grant deadline tomorrow that I've been working on to get a tool for data collection accepted by the FDA for any kind of opioid, so that we can then apply that, because we're using that for the low back pain study. I think that there's two others, pelvic pain and using two different motors contralateral to each other for post-op total knee replacement. Those are the next studies that I'll likely be pursuing after I'm finished with the low back one.
Great. Now, I really liked when you kind of touched upon this multimodal approach and gave us some nice rationale as to why we might do that, because that's sort of backing up a lot of the research. And traditionally, some elements of chiro have been more a monotherapy in their application. So I think that that's not so much the case in in sports chiro. So I was really interested to hear all of that. But is there much in the way of data in terms of what combinations work best? You know, like for cold compression, what about adding motion of nearby joints? And you also mentioned the effect of stimulation on proximal areas to the injury area. Could you elaborate on a little bit of that, please?
Sure. I think the point of the study that I shared is that even with 90 odd studies, there isn't a consensus. So I think that should actually tell us that there isn't one right answer. Human beings in this day and age are trained with multiple choice tests, and we want to believe there's one right answer, but physiology isn't that simple. So I think that at this point, with all of the studies that have been done, if there were a right answer, we would know it. And so that's the right answer. There isn't a particular optimal combination of any of these things. And the proximal part is simply that that because you're not when you're using focal mechanical stimulation or MSTEM, you're not doing massage. Yes, if you put it directly on, you can get some benefits of vasodilation and you can get some benefits of separating the muscle fibers. But if you're using it for pain, primarily what you're doing is blocking the nerves. And so with that being said, it doesn't really matter if you're directly on it or proximal, so long as you're in the same dermatome to stop the transmission. Case in point, when I was using a mechanical stimulator to inject lidocaine for some sutures on someone's leg, is the benefit of, let's see if I can do this at home. Yeah. Okay, there you go. All right, here you go. Here's your laceration. I had the unit right here, and I was injecting, and then she screamed. Too racy. My first thought was, I've gone out. That's a very narrow band of how much numbing you get. But realized later that it's the dermatome. All of a sudden, I was no longer blocking in the same dermatome. Then I was just adjacent and maybe doing some distraction. So likewise, when you're stimulating the Pacinian nerves, you can really do it anywhere in the same dermatome. There's some people who are using the 200 hertz distal after a knee arthroscopy, and some use it proximal. It's that I think there may be an answer to. I think proximal is probably better, but there's not enough research yet. But either way, so long as you're in the same dermatome, you don't have to actually be at the site because you're blocking pain with a nerve. You're not trying to mask it with cold or with another sensation.
Okay, so that leads me now to going back to some older approaches within chiro, where many chiropractors would say if you've got a problem with the C5 dermatome, that they would adjust or manipulate the C5 facet joints to have an effect on the entire dermatome. Now, based on what you just said, that there may be something to that from the perspective that you're presenting. So what would be your thoughts on that?
Yes. Yeah. I mean, it's if you've seen shingles, that the nerves go all the way down in a stripe. And so unquestionably, it's coming from out of the spine and going everywhere down the body in very well described and well-known areas that you can delineate. So unquestionably, the working with the dermatomes for pain and pain blocking. And when you've got pain that's transmitting, it may be relayed on the nerves and coming from a place where it's not as obvious. One thing, another really fun new discovery, 2018, there's something called an SR2 protein, and it's called a chaperone protein for pain. Basically, you can radioligand mark it and then do a PET scan, and you can see where pain is actually happening. And so, because these proteins are created in response to where the pain is being generated. Example, that the 2018 paper was someone who had an amputation and they couldn't find a neuroma or where the pain was coming from. So they radiolabeled the SR2 protein and then looked at it, and they could see that there was one spot where it was coming from their leg. They ablated it, pain was gone.
Now, if you don't mind, I'm going to return you back to the heat versus cold debate, because we've been hearing a lot lately in the sporting world that we shouldn't be focusing too much on the cold, which has been a more traditional stance, and we should be applying more heat. Now, the role of the ACG there that you mentioned earlier is basically what the patient believes to be best for themselves is probably the road that we probably want to go down. Thoughts on the use of one or the other, and what role the patient's value system and their preferences come into all of that?
So twofold. So one thing that the ACC does is the ACC is juggling, but it more as a distracting from pain kind of thing than it is with the frontal area that's shifting through different options. The best way to engage the ACC is to have a task like looking at a sentence and saying, okay, how many of the thanks and questions, how many of those letters have holes in them? So 1, 2, 3. It's a thinking fast, thinking slow thing. But it's all it's an additional technique, particularly for very intense pain. My personal belief is that the rise in interest in heat is because there are heat products, and I think that the industry is driving the belief rather than the physiology. So I do believe that being able to alternate the heat and cold may be doing something in the periphery, but I don't think it's doing something centrally. And so I am willing to wait until we get more data on whether a rapid transition, is it activating the ACC? I think it probably isn't. I think it's probably doing something in the periphery, but I don't know. But I think that for the purposes of how the brain processes pain, it's much less likely that that's going to get up to the central brain, because the substantia gelatinosa in the dorsal column has so much mitigating power that it's going to give you an average sensation up to the brain. So I think if you're doing rapid back and forth manipulations, the dorsal column is going to largely erase some of the effect of that. Until I see the fMRI data, I'm going to be a little skeptical on it and think that it's more that the patient believes something good is being done for them. So to that effect, I believe that it's more helpful for the patients to empower them to have access to both heat and cold and let them do what feels best for them. Because as we saw with the Durenji study, where heat versus cold really didn't make a difference, and because of what we know about how agency and intentionality feed into pain management, I think that with the exception of a very acute injury where you really want cold, we'd have no data that cold is bad for you. We have industries that have a vested interest in saying that heat, cold, flip-flop, flip-flop, flip-flop is good for you. And we know that from the patient's standpoint, different temperatures work better at different times. So controversial, but that's kind of what I think.
Thank you very much for that. Look, I think we've been going long enough now, and it's coming up 3 a.m. your time. So I think it's time for you to go back to bed or get that the final response to your grant that you have to finish up. Thank you again for your time. Yes.
I would like to learn from you I'm going to stop sharing, but do you have data that makes you feel that heat-cold interaction is going to be something, what mechanism it's decreasing pain if it's not patient's belief?
Just my 35 years of observation, and in reading some review papers on, what is better for acute injury, it seems like it's convention which dictates a lot of that. That's older studies. I must admit I haven't looked at more recent ones, which is why I was interested in your talk in the first place, because you're going over that. And you're telling me that there's not a lot of difference, which is interesting.
Not for acute. I think for acute, it's ice all day long. But yeah.
And what about the chronics though? Because I would say that based on patient preference, they're almost always going to say heat, unless they're in a hot environment.
Yeah, I really think it's patient preference that dictates. And what I have seen with our study is that if the chronic patient wants ice, then it's usually because there's an acute on chronic that has exacerbated it somewhat. But the heat is decreasing spasm and is also going to change. It's more of a central reducing hypersensitization type thing. So yeah, I totally agree with you on. In general, I think, in fact, I wasn't a believer in heat until I broke my neck and then had spasms like we've talked about. So I think there are devices now that do very rapid alternating of heat, cold, heat, cold, heat, cold. And I think that that's more a product in search of a solution rather than the tissue part. But no, I agree. I'm an ice acute and heat chronic, but I think that it's the patient's preference probably weighs more than either of those. So sorry to have left a misperception.
That's pretty much the way I've approached it over many years, and I think most sports chiros do as well. And until there's direct evidence to say otherwise, I think that works fairly well. I'm just noticing my increasing redness here because I spent some time out in the sun before we came online here today. So I'm not having a hypertensive episode, but I am feeling a lot of heat and feeling not too bad. So I'm all good with that. So yes, once again, thank you very much for your time. That was fantastic, that presentation. I've learned a lot and I appreciate your time and your input. If we have any other questions, I'll forward them to you and we'll go from there. And just so that everybody knows, we'll get a copy of this presentation up on the Fix website. And in addition to that, we'll have a copy of the PDF of the slides as well. So once again, thanks very much for your time and good luck with your research and your product. Thank you.
Thank you so much, Henry.
Cheers.